Thanks everybody for being here. We've got a good crowd today, and I'm really happy to go over this topic again. It's one of the topics that I don't think you can do enough justice to. You can't beat it too much to death. I want to give credit to Dr. Ahuja, who is a member of our infectious disease division here at Prisma Midlands USC School of Medicine. And I see that we have multiple people joining us from my department and area, and they will know that I'm cheating a little bit because Dr. Ahuja did this as part of his presentation to our department a few weeks ago. And I do have his permission to use his slides. I've added a few slides to it, but I have it was such a nice review and so important for us to go through. I wanted to present it to this group. So thanks for putting up with it. And you might, Rachel, as we get to our discussion later, there may be a need to come back to a slide or two. So I'll try to keep an idea of what number the slides are so that we can reference them. But syphilis is such a huge problem. When I was a resident, we saw it a lot. Then I moved to Kentucky, and I was in Kentucky for 26 years and maybe saw 4 to 6 cases of syphilis the whole time I was there. It was remarkable how regional it was. Um, the incidence has increased so significantly in the United States over the last 5 to 8 years. It's remarkable. Over almost 4,000 cases of congenital syphilis have been reported to the CDC in 2022, just in 2022, a significant increase, 184% increase over the past 5 years. And it's the highest rate in over 30 years. Next slide. In an open letter to healthcare providers from the CDC, as well as all of these professional organizations, they stated that we must emphasize counseling during our prenatal counseling, that we need to screen regardless of age, regardless of relationship, sexuality, etc., all of our patients that we see for prenatal care and at delivery. Next slide. So often we've used risk factors to help screen, and we found that that is not good. So in this slide, this is a great paper that just shows the increasing incidence of congenital syphilis. This was a group of hospitals. I think it was 6 hospitals that they looked at the numbers, and there was a year over year 24% increase in congenital syphilis, with a high association of low socioeconomic status, of insurance, Medicaid, and no insurance, race, and ethnicity. So you can see that by 2020, the rate was at its highest. Next slide. And this shows the relative risk associated with preterm birth and congenital syphilis. So almost 2.5 times higher incidence of preterm birth before 34 weeks in babies with congenital syphilis. I'm a little bit surprised, no real increase in incidence of low birth weight or in hospital mortality in the neonate. Next slide. So the updated information from ACOG, and I have to say I had missed this. I had heard about it, but Dr. Ahuja brought it to our attention that ACOG's committee opinion in 2024, April, suggest that we do serologic screening for syphilis at the first prenatal visit. We do rescreening in the third trimester between 28 and 32 weeks, preferably before 32 weeks, because we need to have that patient treated 30 days or more before delivery for it to benefit the neonate. And then universal rescreening at birth. No risk-based approach to screening. So this slide I like because it gives me gives me pause, makes me think about medical school and residency. And I actually like these kind of diagrams, but it makes it very simplistic to show you the different time frames between infection, primary syphilis, secondary syphilis, and then to help understand where that latent syphilis is occurring. And that's between the secondary and tertiary syphilis, where the disease becomes dormant. Early latent phase is when it's been less than 12 months. Late latent is if it's over 12 months of infection in the patient. Next slide. And this is one that I think is very clinically uh, able to kind of correlate what we're seeing with our testing. So you see with specific treponemal testing, those antibody tests will become positive as quick as 2 weeks after infection. And it's always positive after treatment. The RPR, the non-specific testing, will be delayed up to 4 weeks after infection before you start to see a rise in the RPR. If no treatment, it generally will stay elevated until the patient gets to that latent phase. But if you treat the patient, you should see at least a fourfold decrease in the RPR in the first year. So a fourfold decrease in the first year. That's just a very important clinical number to see. Go back to that slide again. The last dotted line is one that I really want to bring people's attention to. And now that we're really doing more testing for syphilis than we used to, I'm beginning to see patients who are treated, but they continue to have a positive RPR or VDRL. And if that test remains positive, that's labeled as a serofast state. So up to 14% of patients will continue to have a positive RPR forever and a day. It's generally less than a 1-to-8 titer, but they are always positive. So that's called a serofast. And it can be very confusing. And I think what it leads to is sometimes patients are treated multiple times when they actually have cured disease. If there's concern or question about the titers, the CDC has an STD clinical consultation network that you can go on to the website to CDC and you can call them and they'll help you right there. You can share the labs with them and they can give you advice on whether they would treat the patient, not treat, or do further testing. I think that's they have it's a great resource and I've used them several times. Next slide. This is a fact that I did not realize. Dr. Ahuja taught me this and did not remember. 2/3 of untreated patients will clear the spirochete spontaneously, which is very interesting. 15 to 30% of untreated patients will develop some late manifestation. And the most common is cardiovascular, but it can be ocular, it could be neurologic. There are many aspects that it can affect. It's unpredictable progression to late disease as well. It's more likely in men than women. Blacks develop more cardiovascular syphilis than their white counterparts, and whites develop more neurosyphilis. Next slide. This is a terribly busy slide, and I'm not going to get through it, but it is a very good resource. I would print this off and have it in your clinic for primary care, for pediatrics even, so you can refer to it if you take care of children, so you know what we do. I'm going to go through some of this as we go through the talk, but this is a great reference on the testing algorithms that we utilize and how we respond to those. Next slide. So just quick slides through some lesions. This is the chancre. It's the primary lesion that occurs 2 to 6 weeks after the infection. Painless. It doesn't look painless, but it is painless, and it will resolve in a few weeks generally, and a lot of people don't bring any attention to it. Next slide. Some more lesions. The A frame is a vaginal chancre. And then the other two frames, B and C, are secondary syphilis, a condyloma lata to the right. And on the left, it's the alopecia that you see with secondary syphilis. Next slide. And this is that maculopapular rash, classic appearance, and it's over the palms, the feet, and the torso commonly. Next slide. And this is condyloma lata in frame A in the throat. In frame B is another condyloma lata of the tongue. And then you can see the rash, feet, hands, and torso. Next slide. And more of the secondary syphilis. The secondary syphilis lesions generally will come up anywhere from 2 to 12 weeks after the primary syphilis has resolved. And this is painless as well, but very, very infectious. Next slide. And congenital syphilis, these babies can be born with no symptomatology at all. We've talked about how the numbers have increased from 334 per year in 2012 to almost 4,000 in 2022. Is tremendous. 38% of pregnant women who gave birth to infants with syphilis received no care, and 37% either didn't receive any testing or weren't tested early enough. But altogether, it's estimated that 90% of congenital syphilis cases are preventable. Next slide. And there's really a significant disparity. If you look at Native Americans, they have one of the highest rates of syphilis and congenital syphilis of any population, followed closely by Blacks and Latinos, and much greater than their white counterparts. Next slide. Now, in obstetrics, we need to have a keen sense of curiosity about diagnosing syphilis. When patients are diagnosed with syphilis during pregnancy, we need to remember about the vertical transmission and do our best to look for indications of that possible vertical transmission to the babies. In utero, it can lead to enlarged fetal liver, which sometimes can be difficult. Those of us used to looking at the high-risk scans do look at the liver and can tell when there's hepatomegaly, fetal anemia. The placenta gets really big and fat and fluffy. Increased amniotic fluid is common, and something that we work up if we have a baby that has non-immune hydrops. We always evaluate that pregnancy for the possibility of syphilis. The absence of ultrasound markers doesn't mean the baby doesn't have it, though. If everything appears normal, there's still a 12 to 15% risk that those babies could have vertical transmission and have no markers. Next slide. Just more pictures of an affected baby, and I will leave this to Dr. Mubarak and Dr. Witherspoon and others who have pediatric experience to tell us how to diagnose neonatal infection, but many times they do not have clinical outward evidence of syphilis. They do evaluate placenta for infection. I've been asked by our pediatric ID person to have that done before when we suspect it, and neonatal IgM levels may have a role but then also going and doing other studies on the baby. Next slide. Go back one. There we go. So syphilis treatment, everybody knows penicillin is the treatment of choice in pregnancy. It does cross the placenta. It's the only efficacious therapy. If the patient is allergic, we do allergy testing. If they're truly allergic, then they need to be desensitized and treated with penicillin. Treatment less than 30 days before delivery is inadequate treatment. So they have to be treated before 30 days before delivery for it to be considered adequate. And again, we talked about adequate response of a factor of 4 on the treponemal titers, and that it sometimes takes a year, sometimes even a little more. The Yerrick-Herxheimer reaction is real. We see it. Up to 40% of women treated for particularly primary and early and secondary early latent will have the JH reaction. It's characterized by nausea, vomiting, fever, muscle aches, cramping, diarrhea, can lead to hypotension. But you treat it symptomatically and they do respond well. If they have more than one episode of syphilitic infections and you're treating them on the second or third try, the risk of this reaction also increases. Next slide. So hit the clock here. We're good. This is a study looking at almost 1,500 patients. It was reported in our journal recently, showed that almost 60% of patients from this study group of 1,500 women were adequately treated, but 42% were inadequately treated or not treated at all. So inadequate treatment would be they would come for one injection, but didn't come back for the second two benzathine penicillin injections. 82% of this cohort received timely prenatal care. So it wasn't a lack of care, it was just a lack of appropriate treatment. And then 32% of the patients with timely prenatal care just weren't treated adequately, not given the right doses, and 15% didn't receive any treatment at all. And this is in a cohort that had a lower incidence of syphilis. So it lets us know that if you don't have a high degree of suspicion and you don't do it often, it can be overlooked and lead to really bad consequences. So the next slide shows the best practice advisory criteria. We have this with our electronic medical record. It fires off for all pregnant women in the third trimester who don't have a record of syphilitic screening between 28 weeks and the end of pregnancy. You have to enter a result to close that care gap, and that's vitally important to make sure that we're treating these patients correctly. So this is a way that you can overcome those gaps. Next slide. And this is just the same thing again. We can go on to the next slide. We just need to make sure that we're screening people appropriately. Next, there we go. So just a minute about the algorithms that we use now. In the past, the traditional algorithm was the way we went. It was using the non-treponemal serologic test. That's the RPR or VDRL. And if that was reactive, then we would do the quantitative or the specific treponemal test over to the left. And if that was positive, then we, am I saying that right? Let me look at it here. So we would do this. If it's reactive, then we confirm it with the serologic treponemal test. And then we would treat the patient if it was positive. If it's negative, we assume that's a false positive test. On to the right side, if it's non-reactive, syphilis is unlikely. Now we're using the reverse sequence algorithm, and I'm not going to get into a lot of detail of why. I will go over it for a few minutes, but it is a more specific test looking at the specific treponemal antigen. And if it's reactive, then we go to the RPR or VDRL. Now, just one quick word about the VDRL or RPR. If you're following a titer of an RPR or VDRL, be sure if you're following one, you'd follow the same one to follow treatment. Don't switch from an RPR to VDRL or vice versa. If you do this test and then it's reactive, then the question is whether the patient had previously treated syphilis or whether she had untreated syphilis. If it's non-reactive, then we do a second specific test. And if the patient, if it's positive, she either had previously treated syphilis or it was untreated. And this is very important to follow because it can be very confusing. I get confused talking to you guys about this today. If the second specific test is non-reactive, then on the second time, then syphilis is very unlikely. So the first treponemal test was a false positive, and you can have false positive tests. Next slide. So this is a study that was recently published, I want to say last month. You can go to the next slide. And this is very important. And if you will print this off and look and follow this as a management scheme for your patients, if they have positive specific test and a negative RPR, you then do a follow-up specific test. If it's negative, then the first specific test is likely a false positive. So I'm not going to go down this path. If the second test is positive, so you have two specific tests that are positive with a negative RPR sandwiched in the middle, then we've got a problem. This patient either had syphilis in the past and was treated, or if they don't know, and this is the part that I always struggle with, if the patient denies a history of being treated for syphilis, then you repeat the test, but you have to decide, are you going to treat this patient or not for potential syphilis, even with a negative RPR? Rachel, this is going to be hard to do, but I'd like for you to go back about 5 slides to that graph that showed the curves that go up. Keep going. Here, this is it. And this is the specific thing that I just want to bring to your attention. Remember that the specific treponemal test will be positive up to 2 weeks before the RPR is positive. And this is why we say if there's a discordance, positive treponemal test, the second treponemal test is positive with a negative RPR, treat the mother as if she has syphilis, and then continue to follow those titers. You can go back to that last slide now. And that's about as clear as mud, I'm sure. If you don't do this, keep going. There. This is where we are. So you would be here and you would treat this patient. What happens very often is that the RPR will become positive. What if that RPR never becomes positive? And this is an important tidbit to remember. 25% of patients with latent syphilis or late, early or late latent syphilis will have a negative RPR. Say that again. 25% with latent or early latent syphilis will have a negative RPR. So the reason that I choose, and the residents know this, and my partners know this, I almost always treat the unknown duration syphilis with 3 injections of weekly benzathine penicillin. And you just can't be safe enough in these cases. So that's my take on this. If they have 2 positive specific tests with a negative RPR, I treat with 3 injections. Next slide. I think we're just about done. Go on to the next one, and these will be available to you. This is basically going through the benefits or drawbacks to doing the traditional algorithm versus the reverse algorithm. Basically, what has been shown is that the reverse algorithm is easier, more easily reproducible. It's cheaper because of the mechanism of the test, the specific test, and the mechanism of the non-specific treponemal test. So we keep going back and forth. One of my partners really does not like this reverse algorithm, but I think that that's what we're going to see utilized around the country moving forward. The CDC is really pushing us to do more of the reverse algorithm